Anesthesia. Anesthesia is the loss of sensation with or without the loss of consciousness. We talk about anesthetics that induce anesthesia. Different routes that we talk about are local, spinal, inhalation, IV, and topical. General anesthesia is often given IV, and it includes 4 stages. It can also be given via inhalation. Stage 1, analgesia. Stage 2, excitement or delirium. Stage 3, surgical. Stage 4, medullary paralysis. Inhalation anesthetics, often used for surgery, include methoxyflurane, enflurane or ethyrane, isoflurane, desflurane or suprane, and sevoflurane. So you can see all of these have the flurane in them. So it's easier to remember that these are anesthetics for inhalation when they have a flurane in them. They can be combined with a barbiturate like thiopentanol or a strong analgesic like morphine, and also a muscle relaxant like pancuronium or vecuronium. Adverse effects of inhalation anesthetics include respiratory depression, hypotension, dysrhythmias, and hepatic dysfunction. So you can imagine during surgery, before somebody goes in, if they're going to get these medications, it can include hepatic dysfunction. So we're going to check LFTs before they go in. If the adverse effects can include respiratory depression, there's somebody always managing the airway. Perhaps they are ventilated. Hypotension, we're watching that blood pressure. Dysrhythmias, we've got them on a cardiac monitor. One of the adverse effects can be malignant hyperthermia. So we're also watching for that. Local anesthetics block pain at the site where the drug is administered. Consciousness is maintained. Hey, they use it in a lot of dental procedures. Suturing skin lacerations, short-term minor surgery localizing just that area, blocking nerve impulses like a nerve block below the insertion of, say, if it's like some kind of a spinal anesthetic, and diagnostic procedures such as lumbar puncture and thoracentesis. Those things really hurt, so it's nice to have that local anesthetic. Procaine hydrochloride or Novocaine, lidocaine hydrochloride or xylocaine. Usually the canes fit into this category. The ester group in this local anesthetic category are procaine, benzocaine, chloroprocaine, cocaine, cyclomethicaine, dimethicaine, lidocaine, piperacane, propoxycaine, and procaine or Novocaine. Just an FYI, as far as controlled substances are concerned, docs are the only ones that use the cocaine. They will use it on a really bad nosebleed. Do not pull that out of the Pyxis for them. They need to pull that out under their own name. But at any rate, if you see a cane, it's usually some form of local anesthetic. Lidocaine is one of those things that used to be thought of as okay to administer via the ET tube if there was a emergency, but nowadays we use intraosseous medications a little bit more often than that. Intravenous anesthetics include propofol, etomidate, and ketamine. You've probably heard of these if you work in an ER. So also droperidol. Droperidol, etomidate, and ketamine, they have rapid onsets and short durations of action. So they are really great for sedation procedures that might be done in the ER. even greater rapid onset and shorter duration of action is that propofol. It leaves the body quite quickly. It's very helpful to be used there. If you use something like midazolam or Versed for someone for some kind of a sedating need, it usually sticks around the patient a little bit longer, especially if they're elderly. Just an FYI, from anecdotal experience, I've seen ketamine used in kids, and it is really, if you've got an autistic child, autism and ketamine are kind of a really miserable combination. It's a very scary drug for them, so try not to use that. A lot of times we will use laughing gas instead of some of these things for kids for procedures nowadays. Propofol, just an FYI, kids metabolize it really quickly, and they're really good at metabolizing of it. So whereas most drugs you have to dose a smaller dose because of the size of the child, propofol's one where you may end up giving more because they metabolize it so quickly. Topical anesthetics. We want to get everybody familiar with these and that they are available because these are things that make some of the procedures that we do just a little bit better. Placing an IV is so much better after having LET or ENLA cream on the site. LET is often put on areas that are going to be sutured. Oftentimes that's also followed by some local anesthetic provided by the doc, but this actually helps when cleaning it and throughout part of the suturing. The EMLA is often used prior to IVs being placed. There are some wonderful products that are out there that allow for quicker response time than EMLA as far as numbing an area. Some commercialized products that are just wonderful. Lidocaine patches are also used. The big thing with lidocaine patches is they are a 12 hours on, 12 hours off. You can actually end up with cardiotoxicity from the canes. If you think of cocaine, you think of heart problems, right? So this is lidocaine. It sits in that same family. And so 12 hours on, 12 hours off. What you want to make sure to do in the MAR when you're taking care of a patient that has one of these lidocaine patches is make sure that there's somewhere in there that says to remove it also for a certain duration. Topical anesthetics, they're used on the mucous membranes, so broken or unbroken skin surfaces and burns. They come in solutions, liquid sprays, ointment, cream, gel, and powder. They decrease the sensitivity of nerve endings in that affected area. So just remember that they can also produce that cardiotoxicity. So make sure that that is somewhere in the chart as a safety measure to remove them. Spinal anesthesia and spinal blocks. So local anesthetic is injected in the subarachnoid space at the third or fourth lumbar space. Side effects and adverse reactions include respiratory distress, headache, hypotension. The perioperative visit by the anesthetist and or the preoperative visiting nurse is an important stage in gaining the patient's confidence when explaining a spinal anesthetic. A brief, simple explanation of the procedure is necessary in order to reassure the patient. So this does hurt when it goes in initially. So a general anesthetic can be required if an adequate block is not achieved. Hypotension is often a common side effect following spinal anesthesia. It's important that intravenous access and fluid therapy are in progress. That's if you have somebody whose blood pressure dips, you want to be able to open up that fluid and run it in so that you can bring that blood pressure back up. Psychological and emotional support is necessary for patients undergoing spinal anesthesia and it can be a frightening experience. Like I say, it hurts to go in. But once it's in, it's fantastic. Hands to hold are great interventions. Spinal block, there's a penetration of the anesthetic into the subarachnoid membrane, the second layer of the spinal cord. Epidural block, placement of the local anesthetic in the outer covering of the spinal cord or the dura mater. And a caudal block, placed near the sacrum. There's also a saddle block administered at the lower end of the spinal column to block the perineal area. Anything that's saddle has to do with the area involved sitting on the saddle of a horse. So that might help you remember that. Balanced anesthesia. That's a new term, right? Balanced anesthesia may include a hypnotic given the night before, pre-medication with an opioid analgesic or benzodiazepine, plus an anticholinergic to decrease the secretions, a short-acting barbiturate such as thiopental or pentothal, an inhaled gas, so often a combination of nitrous oxide, laughing gas, and oxygen, and then a muscle relaxant like pancuronium even, that's a pretty harsh one. But ADPIE in anesthetics. So remember, ADPIE is still how we're remembering the nursing process, but as far as ATI and NCLEX are concerned, they've taken out the nursing diagnosis of the nursing process and want us to focus on the problem instead. Nursing assessments and intervention monitor that patient's level of consciousness, their vital signs, not just their vital signs, but also their oximeter probe should be on, and you should be monitoring their oximetry. We want to monitor urine output and administer analgesics cautiously. And that's the end of the anesthesia lecture.